And we're going to be talking about trauma-informed care for abuse survivors. I'm having trouble talking, apparently. So I'll let Elizabeth talk a little bit about some housekeeping things, and then we'll get on our way.
Okay, so if you are not speaking or presenting, we're going to have you just turn off your video. I know that's sort of counterintuitive to trying to create discussion, but we do find that it helps with our bandwidth and makes sure that we can hear and see our presenters really well. Please, at any point, feel free to chat in your questions for our speakers. You can also share who you are and where you're from so they get a sense of who's on the call. We'd love to know where you all are working. And then there will be time for that Q&A after. So we will keep a watch on the chat and collect all your questions and turn it over to our speakers to help answer those at the end. It says WebEx, but this Teams meeting will be recorded, and we're going to make that available at kh.org/caregiver wellbeing at the end. So we are able to offer continuing education credits for this, and our presenters have none of the financial relationships or commercial to disclose. And Dr. Peterson, would you like to introduce our speakers?
I would love to. I am excited today to introduce Amanda Cryer, MS. She is the Executive Director at Safe Passage, which is a local nonprofit that works with people who have or are experiencing domestic and sexual violence. She graduated with her Bachelor of Science in Criminal Justice from Adelphi University in Garden City, New York in 2012, and soon after earned her Master's of Science in Criminal Justice with a concentration in victimology from the University of New Haven in West Haven, Connecticut in 2013.
Oh, that worked out good.
In 2014, she moved home to Coeur d'Alene and has worked at Safe Passage since. This year will mark 10 years working with victims of violence in our community. And we also have a team presentation today. Typically we have one at a time, but today Megan and Amanda work very closely together and wanted to give a team talk. So I will go ahead and introduce Megan Lorenz, who is the manager of the Forensic Nurse Examiner program at Kootenai Health. She received a Master of Business Administration from the Washington State University and a Bachelor of Science in Nursing from the University of North Carolina at Wilmington. She's been a nurse for 15 years and with Kootenai Health for over 9. Her background is in emergency nursing, where she found a passion in caring for patients that have been sexually assaulted through the opportunity to connect with them. And
they have the Medicare Advantage plan.
As they begin their journey to healing. This passion and experience led her to an opportunity where she developed an on-call sexual assault nurse examiner program for the Spokane County hospitals through a local victim advocacy agency, and eventually to her current position, expanding care beyond sexual assault to also caring for patients experiencing domestic violence, elder abuse, child abuse, violent crime, and human trafficking. In addition, Megan also works with local prosecution in both Spokane and Kootenai counties as an expert witness and serves on the board of directors for Safe Passage. In her spare time, she enjoys paddleboarding, skiing, and traveling. So I am very honored to have both of you here today to talk about this topic. And I will turn it over to you.
All right, Megan, if you want to share your slides.
Yeah.
Okay, we're gonna mute ourselves and go off camera, and this is all your time, ladies.
Thank you.
Okay.
We have the presenter view, so you want to flip your screens, I think.
That's it. Sorry.
No worries.
Just share the screen. Maybe. Oh my goodness, it still just keeps wanting to shoot it over there.
That's okay. Up on display settings in the top bar,
Oh yeah, just turn it back on to it.
just swap. There you go.
Okay.
Beautiful.
All right. Well, thanks, Dr. Peterson, for introducing us. Amanda, was there anything else that you want to talk about Safe Passage and the program over there?
Yeah, we're just the local nonprofit. We've partnered with Kootenai Health for years and being able to provide free and confidential services to victims, specifically around domestic sexual violence, human trafficking, stalking, as well as kids that have or are experiencing physical or sexual abuse. So all of our services are free, confidential to anybody, anywhere. If anybody needs any type of services, you can definitely reach out to us.
And Safe Passage also houses the Children's Advocacy Center, which is over here on our campus next to the Crisis Center, where they do forensic interviews and follow-up medical interviews for children that have been victims of child abuse. Great program. They have a wonderful courthouse facility dog. Her name is Lucy, and she's super cute. So,
Very.
yeah. And then the Forensic Nurse Examiner program started up last year. We went live in May in the emergency department. Our on-call team of nurses cares for all victims of crime, from sexual abuse, child abuse, elder abuse. We do domestic violence, violent crimes such as shootings and stabbings, and provide comprehensive care, evidence collection, medical forensic photography for those patients, as well as safety planning and things like that. And then our nurses also testify as expert witnesses in court cases as well. So today we hope that after this presentation, you will all come out with a better ability to recognize the prevalence of patients with a history of trauma. We hope you can identify some tips and tools for how to care for people that have experienced trauma and how to be a trauma-informed provider in all of your interactions with others.
Okay, so we're going to talk about nationally. We wanted to bring statistics into this presentation to have people realize the impact and the amount of violence that's happening, not just nationally. We'll talk about the prevalence in our community too. Also, there's some things that we'll talk about today that if it is triggering, because we know that people have experienced violence in their lives, it might not be the violence that we're specific on today. There might be other types, so we want to recognize that. And if there's at any time you need any support, please let one of the main presenters know, put it in a private chat, whatever that looks like for you. But making sure that you take care of yourselves during this presentation, because it can be a lot to people in general. So when we look at about statistics, this is nationally, we see that violence is happening at high rates. We see about 1 in 3 women, 1 in 4 men experiencing sexual violence. When we talk about kids, we see about 1 in 4 girls and 1 in 13 boys specifically experiencing sexual violence in our community. When we look at the cost of sexual violence, we see that at a high number, and that's going to be with medical services, that's going to be with therapy, that's going to be consistently throughout their lives of things that they need to heal for and with, that we can see that that impacts our community, especially within the money realm too. When we talk about Megan, you have anything to put in that?
Nope, we got it all.
Oh, look at that, slaying it already. When we talk about intimate partner violence in the nation, we see about 1 in 5 women and about 1 in 7 men. They have experienced severe physical violence. 1 in 5 women and 1 in 12 men have experienced sexual violence by an intimate partner. We see a higher rate of stalking if that's during an unhealthy relationship, if it's domestic violence, or after maybe that relationship has ended. We see that stalking can and is happening afterwards. We work within the school systems with teens to talk about healthy relationships, to talk about green flags and red flags. But we do see a high rate of teens that are experiencing domestic violence in their relationships, as well as sexual violence. And we see that down there, about 1 in 12 for physical and 1 in 12 for sexual violence.
And unfortunately, these kids are getting younger and younger, 11 to 12-year-olds that are starting to experience this while in school.
When we talk locally, these are our numbers here at Safe Passage. You can see that we have sheltered, so we have a safe shelter for anybody experiencing violence, about 260 adults and their children. There's an increase from last year. We have crisis hotlines coming in for people that wanting information, want to talk to an advocate 24/7 about something happening in their lives or somebody that they know. We can see that number went up 8% last year. We're in the court, going through the court system. There was 473 people that we helped. That number has increased. Overall, we helped about over 1,300 people last year and a total of 2,100 contacts. So we know that the amount of people we served was about 1,300, and then we helped them throughout that process. That 208 number is going to be kids that have been forensically interviewed. So there's going to be some sort of sexual or physical abuse that might have happened. And so that they will go in and talk to our forensic interviewers in a trauma-informed way to make sure that they're asked non-leading questions. They can talk to kids about things that might have happened to them and use that as evidence to further on that criminal justice process. That is our sweet Lucy in the top right corner, our facility dog who gets to snuggle with kids when they are talking about tough things that have happened to them. And then we reached about 2,000 students with our healthy relationship curriculum in our middle schools and high schools. So statistically in our community, we see about 1,300 to 1,500 victims of domestic violence. We see about 100 to 150 of sexual violence. And then for kids, we see around that number, about 200 to 250 a year that go through our Children's Advocacy Center.
And our numbers here at Kootenai Health, last year we had roughly 400 identified that were victims of crime that came through our doors here at Kootenai Health acutely as victims of crime. So when we're talking about trauma-informed care, what we're looking at is helping to build a framework for how we relate or help those that have experienced negative consequences after these traumatic life experiences. So these are events that are emotionally or disturbing or life-threatening, but they can lead to a long-lasting adverse effect on their mental health, their physical health, their social engagement, and their overall spiritual well-being. These can be things like physical, sexual, or emotional abuse, maybe it was childhood neglect. They could also be living with family members that have mental health or substance abuse disorders, poverty, racism, discrimination, violence in the community, war and terrorism. And what trauma-informed care seeks to do is acknowledge that those events in their life are part of a complete picture of everything. So the past and the present all that stuff together affects their overall health and well-being. And in order for us to provide effective health care, leaning towards a healing orientation, we need to recognize how those affect them. But also recognizing that how a patient was treated in the past in any sort of situation can affect how they react in the present. So if you have somebody that had a very negative experience as a patient in your hospital, unfortunately, they might be less likely to come back or be fully participatory in their care. So by recognizing how that past trauma can affect their current trauma can help you build a trauma-informed framework. Do you have anything on that one, Amanda?
We've just seen clients of ours that have come in that might have had an experience in healthcare that maybe they were asked a question or they didn't feel believed, or they were asked something in a way that didn't feel safe for them to talk about their experience. So if something happens again and we say, please, let's go get medical care, there's a little hesitancy reaching out for medical support.
Yeah, so it's really important that, at the foundation of trauma-informed care, you are committing to that trauma awareness and to understanding the impact of that historical trauma or oppression. Whoops, sorry about that. And how that can affect them in order to create that safe space, restore that patient's power, and help rebuild their self-worth. And these are some other ways that you can go about creating that safe space, giving the power back, and building that self-worth for that patient. There are 4 R's in trauma-informed care. Again, it starts with realizing that trauma can affect patients' behavior, recognizing those signs and symptoms, and then responding in a way that can demonstrate that you understand their trauma response. And then at all times, resisting that re-traumatization by using interventions that provide emotional support. So as Amanda talked about, if not being believed can carry such ramifications, then how do we address that? And through a patient-centered and trauma-informed approach is how you can address some of those negative consequences from those previous experiences. So making sure that at the very root of everything are the patient's needs, and recognizing the impact that the trauma can have on that patient through everything that you do while you're caring for them. So looking overall at trauma-informed care, instead of looking at just what is wrong with the patient, looking more at what happened to you and recognizing the holistic. I am really sorry. I don't know why these slides keep jumping ahead. By recognizing that all of these past experiences and pieces of somebody's life have a deep impact on who they are as a person and their overall health, and shifting that focus and making it more holistic and patient-centered can really help you build a trauma-informed care practice. Man, do you have anything to add?
I would just say, we have clients that come in that maybe in the front, when they show up in a crisis mode that might come off a little different or extreme. And instead of us being like, oh, there's a mental health issue, or this doesn't sound believable, or, whatever that looks like, we think about it in a sense of something's going on to make this person have this reaction to whatever is happening. So just changing that focus in the brain of, yeah, these things might seem a little extreme of what they're saying or doing, but what brought that person to that spot? And usually when we find that out or ask deeper questions around that, it makes more sense.
And one of the easiest things that you can do to be more trauma informed in your practice is not asking why questions. Why can carry such a judgmental tone. Why were you wearing that? Why were you doing that? Why were you over at this place in the middle of the night? Instead of, can you tell me more about that? Can you tell me how you were feeling when this happened? Can you tell me more about this event that occurred, and just shifting the way that you're asking these questions. You have anything else on that, Amanda?
No, I would just make sure that we're asking more open questions rather than a yes or a no, to get people to feel comfortable and confident to start answering the questions and making sure that we're giving space to answer questions. I think that silence is one of my favorite things, and it's hard to get used to, but giving that space, some silence, and letting your patients or people or whoever that looks like to you, giving them silence to think about it and answer questions when they have the capability to.
Absolutely. So this is from the CDC, and this is their trauma-informed techniques and the different pieces of that that you will put together in order to be more trauma-informed in your practice. Adopting this is not any one single approach. There's not one technique. There's not a checklist. It does require a constant attention, awareness, sensitivity, and then a cultural change at a whole organizational level, and then a constant reevaluation of all of that. So the first two pieces of that are safety and trustworthiness. So we're talking about emotional and physical safety. Do they feel safe here in our organization? Do they feel safe where they're at? Or can the people that they're afraid of get to them? Are they in a shared room? And so not being in a private room, there's fear because there's just another person. Maybe that person has multiple visitors in and out all the time. Maybe they're on the inside of that room where they can't easily get away if they feel that they need to. Do they have lots of lines and tubes so they feel tied down and that they can't get away if they needed to? Is the room comfortable? Are you talking to your patient about what it is that you're going to be doing prior to doing those things? Are you asking permission before you are performing any of the procedures that you need to perform on these patients? Are you being honest and transparent? Trustworthiness is another piece of that framework. Again, setting realistic expectations for patients, maintaining your integrity and being very honest about everything that you're going to be doing and what you're seeing. And then again, I really want to emphasize the asking permission at every step of the way before doing any sort of procedure or doing anything with the patient. The next two pieces are peer support and collaboration. Those that have a shared experience can be very integral to the service delivery. So, you know, in psych, they do a lot of group therapies where these people can come together and share their experiences. I know Amanda hosts support groups as well for people that can come and talk about their shared experiences so that others might learn from them or also feel supported and that they're not alone. It can help them feel more empowered or resilient and help them learn coping skills. Also making sure that we're collaborating with other trusted professionals and upselling those other people that are coming in like, hey, you know, you're going to meet your cardiologist today. His name is Dr. So-and-so, and they're great. They're going to take wonderful care of you. Or Dr. Green is going to be your hospitalist today, and they will come in and ask you some questions this morning, and they're really awesome to work with. So emphasizing that you're also working together with that patient and giving them a voice in their care. Amanda, do you have any?
I mean, I think at the end of the day, it's giving them as much power and control back as you can throughout the process of however you're working with them. Those soft handoffs are really great of making sure they know who's coming next, what's happening next, and giving them that power back is going to be really helpful.
Yeah, and that leans in really well to the next piece, which was empowerment. You know, in order for that, you also have to really listen to your patients and what they're saying, and not just the words that they're saying, but also their body language and how they're responding to you. And truly be sincere when you are speaking to them. So here's a little meme here about how to be a good listener, except for the guy there on your left whose arms are crossed. That's not always a great way to show that you are actively listening to someone. But we're listening in order to understand what they're saying and experiencing, not just to reply to the words that they're saying. Okay. The final piece of the puzzle is understanding how cultural, historical, and gender issues can play a role in their experiences, and how do we need to change up our care in order to honor those cultural, historical, or gender issues. So are there modifications that you need to their care based on cultural practices or beliefs? And you can ask the patient, you know, about those as well, if you're not familiar. being sure that you have reading materials in the languages that they prefer. The various trainings that we have been doing here to provide more culturally appropriate practice. But again, if you don't know, there's nothing wrong with asking the patient about that. And again, if you're asking permission before doing things, they can be more feel safe opening up and telling you about that as well. Understand that historical trauma can play a role in that patient's experience, and how biases and stereotypes can also play a role.
Yeah, I think this also plays a role into the safety of everybody as well. So when we talk about safety and being safer, whatever that looks like for patients, when we think about maybe somebody within the LGBTQ plus community, how are we making sure that they're being recognized for the unsafeness that they have in their community, making sure that if something happens in a certain spot and you're like, well, just use a different gym, maybe that's not safe for them either. So thinking about these different things when it comes to their safety is important as well.
Absolutely. So again, here are the basic principles of trauma-informed care. You know, this isn't about just being nicer. It is an entire culture shift in the way that you care for patients and interact. You have a mindset that everybody is involved in their care, and that care is recovery-oriented and patient-driven. But this can be used outside of just patients that have experienced trauma. This can be used for all of our patients. You know, in shifting the way that we care for them. So make sure that we are respecting their autonomy, their dignity, and their privacy, and returning the power to the patient. So there are 10 key ingredients for trauma-informed care. A lot of the traumatic, there are a lot of different ways that trauma can affect people, and a lot of different traumas that can impact people's life. And all of these can lead to an increased risk of chronic health conditions or risky behaviors that people take in their life. And again, it's not just a clinical practice change by any one person. It is an entire organization that reorients the culture in that healthcare setting to be a better steward of trauma-informed care for their patients, but also for their staff. So we're going to watch, oh, sorry, do you have something, Amanda?
No, I think just to add into that, especially people that maybe aren't used to having conversations around violence or abuse. I know it might sound a little wild, but I would practice these conversations because they can be different. They can feel awkward. And if you're awkward, your patient's going to be awkward, your friend's going to be awkward, whoever you're talking to around this. But making sure that we're practicing these conversations, making sure that if you ask questions around safety in the home, around safety in general, if violence is happening, make sure you're prepared for the answer. So if they're like, yeah, I'm actually super unsafe in my household, what are you going to do then? We had a lady who went to the ER and the ED, and she was just an offender bender, and the nurse comes in and goes, are you safe in your home? And she goes, no. And this was years ago. Now I think it's a little different, but the nurse had no clue where to send this person after that conversation was had. And so, and make sure that we know the answers to the questions. Make sure you practice this conversational piece as well. I also encourage you to mimic the kind of vibe your patients are giving you, because trauma is going to look different for everybody. Language is very huge on that too. So just be prepared for working with people in trauma by practicing and learning a little bit more.
Yeah, I think you bring up a really good point there. You know, if we're asking the questions, and a lot of these questions were required by CMS to ask, you need to be sure that you're asking these questions when people are alone and they don't have family or other visitors in the room with them, because that can be very dangerous for those patients. But absolutely, you hit it on the head. If you're asking the questions, you need to do something about it. You know, you need to know who to go to. If they say no, they don't feel safe at home. Okay, now what? So you have the framework of how to ask the questions, how to be trauma informed in the way that you ask the questions, but you also need to then have, okay, we've asked the questions. Now, how do we provide that ongoing trauma informed care? How do we provide those services and the things that they need after we've asked the questions?
Mm-hmm. Yeah, and I feel like you can do everything right. You're like, I'm following all these steps, I'm doing it great. And people might not disclose violence is happening to them. And that's okay. If you build a space where somebody feels comfortable and confident and they feel like that trustworthiness is going to happen or is in the process of happening, victims will remember that. They'll remember this was a safe place to go. They'll feel comfortable coming back to you or somebody within your circle, and just don't feel deflated if somebody doesn't disclose violence right away. That trust component, giving them back that power component is going to be very, very key into helping victims in the long term as well.
So we're gonna watch a video by Dr. Nadine Burke Harris, and it's about adverse childhood experiences.
Oh, we can't hear it, Megan. Sorry.
That's not helpful.
Do you want me to share on my side?
That would be great. Let me stop sharing, and then maybe I can turn off whatever these timings are that are making my slides go forward.
Yeah, you got it. Give me just a second.
Gotcha.
All right, here we go.
In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer, and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or a packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California. And together, we opened a clinic in Bayview, Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle, and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, Dr. Burke, have you seen this? In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand better than we ever have before how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior, and that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer.
All right, I'm going to pass it back over to Megan. The rest of the video is available online for you to continue watching. We felt that was probably the most relevant for this conversation, and then we'll let you ladies wrap up.
Yeah, thank you. Yeah, I would encourage anyone who has not seen that TED Talk to go and watch the entire thing. She has some other updated ones as well. Let me share my screen again here, where she talks further about this in depth. Some of the most striking things that came out of this ACEs study, the screen sharing, yeah, there it goes. Okay. Was that, you know, these are very prevalent, right? About 67% of participants had at least one. 1 in 5 have 3 or more, and 1 in 8 have 4 or more ACEs. You know, so these are things coming out from childhood. And then how the dose response of those adverse experiences contribute to future and long-term health implications. Some of our leading causes of death. You know, so when we talk about this, it's really understanding how trauma or adverse experiences in life, whether childhood or even as you get older, can change you on a physiological level and really change your brain chemistry, how you respond, how you react, the choices that you are making, your ability to make choices as you go through your life, your healthcare experience, your other interactions with people all around you. Oops, sorry. Amanda, do you have anything on that?
One of the things that we see is we work within the jail system a lot with men and women there, and we see a lot of incarcerated men that are in there for alcohol or drug use. And the amount of men that have disclosed molestation early on in their life is remarkable. It's almost all of them. So seeing that trauma early on in their lives and seeing how that impacted them later on, it probably isn't the only thing, but the correlation between the two is very high.
So this is a graphic that the CDC put together based on the ACEs study and how those can influence your health and well-being throughout your lifespan, which unfortunately all can culminate into early death. But there are some significant impairments to neurodevelopment, social, emotional, and cognitive impairment, and then adoption of risky behaviors, or as Dr. Burke pointed out, some of these patients didn't even have some of those risky behaviors and they still ended in the same place with these chronic health conditions. So as we start to wrap up here, you know, we talked about the prevalence just so that there's understanding that these people are around you all the time. You're interacting with them many times a day. Maybe it's at the grocery store, maybe it's in your family, maybe it's in your friend circle, or maybe it's here as you're caring for patients, passing patients in the hallways, in the cafeteria. So they're around you all the time. And hopefully from this, you can start to build on some tools in your toolbox for how to approach patients with a more trauma-informed care approach and more open, and then understand how to provide that trauma-informed care and start in all of those interactions that you have with other people.
Mm-hmm. Yeah, and I think you're not going to do everything right. You might make mistakes. You might kind of drop the ball sometimes, and that's okay. But I think at the end of the day, if people feel seen, heard, and respected, I think you're doing great. I think these things can be complex in general, and I don't want people to feel like they have to be robotic in the way that they work. But just making sure people are feeling those things is going to be super important.
Yeah, and starting, you know, very small with those small changes, you know, coming more in with a more open mind and accepting of how other people's life experiences can shape the way that they interact with you, and then gradually building and building. This isn't something that happens overnight. This is something that you constantly work towards and constantly add on in order to, start to have a more trauma-informed approach in everything that you do. If you would like some more resources, that top one there is Dr. Burke's website, where she talks a lot more about ACEs and future studies and things that they've done from there. The second one is the Trauma Informed Care Resource Center, where you can learn a lot more about providing trauma-informed care and how to take each one of those pieces and really grow in your practice with those tools. The ACEs study, you can find links to from the CDC. And then the last one there is the link to Safe Passages. All right, and so now this is our contact information if you guys have any questions. And I will stop sharing my screen and open it up for conversation.
Thank you so much for that talk. The numbers that you describe are just absolutely staggering. And the magnitude, the number of people, like you think about 5 people in the room, at least 1 or 2 of them is going to have experienced some form of abuse. And that just is amazing. But we did have one question about the data. If there's, and I almost like, it scares me to even ask if there's any risk for underreporting of that data, because it does seem like that would be something that would be prone to underreporting.
Yeah, I mean, I think our numbers are not reflective on the real amount of people that are being victimized in our community. If you compare numbers to law enforcement's, they are so different because not a lot of people are reporting to law enforcement. But the good part is that they are coming to us as advocates. They're coming to friends, family to get support and help. But we know like 2/3 of sexual assaults go unreported. We talk about kids not having safe people to talk to. We talk about safety and domestic violence. Sometimes people don't want to report because they can't. They don't have the financial means. They can't lose their home. They've got kids. They're so isolated in their space that they feel like if they report this or come get help, they're going to lose everything. And then we think about our marginalized communities. If we're mostly white women that work within our agency. So if I'm a person of color, if I'm Native, if we look like we're heterosexual people and I'm a part of the LGBTQ plus community, if I am a man, those are definitely barriers for people to get help as well. So I know those numbers are not everything happening, but they're coming and finding us. So just making sure people are able to, that would be great if people can share information if somebody needs support.
Yeah, the number of missed, it varies depending on the crime type, but it can be a lot. Congress said that for every 1 victim of human trafficking that we identify, there's at least 6 more that we have missed. And we only identify maybe 1 in 24 elder abuse victims. We miss, unfortunately, a lot of child abuse victims as well. And yeah, as Amanda said, sexual abuse is significantly underreported, and even more so by males.
Mm-hmm.
The average age of disclosure of childhood abuse is about 52, the age of 52, that people finally come forward to talk about abuse that they may have experienced as a child that they never reported.
Wow. And another question we have from Stacy Henning, going back to your comment about make sure you know what the resources are when you ask the question about feeling safe at home. She asks, where do we access resources for patients at Kootenai? Is there a link on the cloud or somewhere that we can go to find resources?
I think we're building some of those, to make them more accessible. Amanda's group is available for domestic violence, sexual abuse, and child abuse. So her group, and they'll do hospital response and come out and talk with patients. We also, social work has access to a lot of resources as well. They can always call our team, the forensic nurse examiners, to run something by us and consult us for things as well.
Stephanie Godinez, if you're able to share, can you talk a little bit about Find Help Idaho that you shared, or any other resources that your team offers as well? Sorry to put you on the spot.
She's still.
She may have had to
She may
jump
have-
off. Yeah.
Stepped up.
Find Help Idaho is a website that coordinates and aggregates all of the different social resources. Oh, there you are, Stephanie.
Can you hear me?
Yes.
Oh, perfect. Yeah, it wasn't allowing me to unmute for whatever reason. Yeah, so a little bit about the findhelpidaho.org is we have partnered. We used to have just a Northern Idaho resource, but we have found that we've needed to expand our resource base a little bit. And so the findhelpidaho.org has all sorts of resources related to some of our social determinants of health, and just really appreciate this trauma-informed care presentation today, as we're going to be really needing to help and support all of our teams throughout Kootenai Health in order to be able to have the best care possible. But Find Help has anything from housing to shelters, to crisis centers, to you name it. And it's all based upon the region and or zip code that you enter in to find. I do know that in the nursing education and resource, I'll copy and paste that in as well. There is a link within that nursing education and resources that will provide that information regarding some of those social determinants of health, and especially as we are asking some of these really sensitive questions, but appreciate the holistic approach to care, where we're looking at the spiritual context of of some of the trauma that some of these individuals have experienced. And so, if there is any opportunities, please do reach out and put in a social work consult, and we'll definitely help to align. I know next week as well, our transitional care department will be part of the 700 huddles, to be able to, if you have any just specific one-on-one questions regarding some of the trauma questions and assessments, that will be there for you as well.
Thank you.
That's perfect, Stephanie.
Yeah.
Thank you.
Thank you for sharing that.
Some other
Okay.
resources. Oh, sorry.
Oh, that's
that are
okay.
out
Go
there.
ahead.
Here, I'll just share this real quick. Maybe everybody can take a screenshot. We have a pamphlet that we have built, and I just need to get it over to the print shop to print it out for us. Well, it's loading very slowly. So here are some resources. You have the National Domestic Violence Hotline and Sexual Assault Hotline. Idaho has the DV hotline. There's Safe Passage there. Lutheran Community Services Northwest supports Washington, and they also do elder abuse and other types of crime, like bullying in schools and things like that. Panhandle, and then the North Idaho Service Directory also has a listing of things there as well.
Great. Thank you.
Thank you. That's extremely helpful.
Hey,
All right. So thank you to our speakers. As in previous sessions, we have a book club that is scheduled for next month related to the topic we just discussed. And the one we've picked for this month is called The Body Keeps the Score, Brain, Mind, and Body in the Healing of Trauma by Bessel van der Kolk. And he is kind of a leading expert in trauma. Talks a lot about veterans and other types of traumatic stress and how it changes the brain function. And how to, another very helpful thing is how to address those changes and make people better. So it is kind of a long one. Again, I apologize. And we've been picking long books, but I think this one's going to be a good further learning opportunity.
it has been on the Amazon top 20 list for over 3 years.
Yeah.
And has
Yes.
4.8 out of 5 stars.
And with 77,000
77,000
reviews.
reviews.
We're fairly confident it's a good one.
Okay, thank you everybody so much for joining us today. We will send out information about claiming your continuing education credits. We really appreciate all of you and hope you have a great rest of your day.